Well, this week at the AAIC conference, Acumen has two presentations that they'll be making. The first one is an analysis of a technique that we used in our phase 2 study that we think really benefited the screening process. One of the new developments in the field is we now have a blood-based biomarker, p-tau217, that is very predictive of amyloid status. So what we did in our phase 2 study is we had 2 screening visits, but in the first visit, their general medical history was reviewed and that sort of thing, but they had their blood drawn for this p-tau217 blood test. At the second screening visit, if they were above a certain cutoff on the blood test, then they went ahead and had either a PET scan or spinal fluid analysis to determine if they were in fact amyloid positive. In our phase 1 study that was done a couple of years ago, that wasn't available, and we found in the phase 1 study that when we did get PET scans on people, about 60% of the time they were negative. In other words, they actually did not have Alzheimer's pathology. What we found by using this blood test in our phase 2 study, that the rate of negative PET scans was only 17%. So it improved dramatically from over 60% negative to only 17% negative. We didn't really want it to be 0% because that would mean that our cutoff was probably too conservative. But by reducing that number of amyloid negative PET scans, it was really beneficial. And the poster that we had this week sort of emphasized the cost savings, which is about 40% of the screening cost, not the cost of the whole study, but the screening costs. In my mind, it's actually more about the burden to the patients and the study sites, because the overall screen failure rate for our phase 1 and our phase 2 are about the same. But in the phase 1, you screen failed by a PET scan primarily. In the phase 2, you screen failed by a blood test. So it's much easier, obviously, if you're going to be screen failed, it's much easier to do it with a blood test than with a PET scan. And so we were actually very happy with these results, and we think this is something that actually could be applied in clinical practice. And we're starting to hear about this anecdotally, that clinicians will draw the blood test, get the result, and then decide whether to get a PET scan or spinal fluid analysis. So we were very pleased with the outcome of that intervention. The second presentation that we have this week is more a biochemical analysis of our antibody, which is sabirnetug. Now, sabirnetug is a little bit different than other monoclonal antibodies for Alzheimer's. It actually targets what we call A-beta oligomers. So in other words, a few of these A-betas kind of lumped together in a globular structure. Some of the other antibodies, for instance, lecanemab targets what we call protofibrils, which are linear long forms of A-beta. And then donanemab, the other one that's approved, actually targets the actual deposited plaques. So the 3 antibodies are intended to work somewhat differently. So what we had in the data being presented this week is that we actually have some biochemical measurements to show that for sabirnetug, the differentiation between binding to A-beta monomers, in other words, single A-betas floating around that are soluble, versus oligomers is over 8,000-fold. And that's substantially more than we saw for an antibody called aducanumab and another antibody, lecanemab. And lecanemab, again, is commercially available now. So we feel like we've really done a good job of being very selective for these A-beta oligomers, which is exactly what this antibody sabirnetug was intended to do.